Good morning. Can you hear me okay? Thank you for joining us at the coronary track CHIP Part 5, Coronary Physiology and Imaging. My name is Bill Fearon. I'm from Stanford, California, and on behalf of my co-moderator, Farouk Jaffer, welcome. We have a nice panel lined up here and a number of interesting talks and case presentations. We're going to try to stick on time, so remind the speakers to really try to mind the 8-minute rule. Farouk, do you want to introduce the first speaker?
On already. Okay, great. Good morning, everyone. Thank you for joining us. Bright and early, delighted to be here. We have a great panel, and we're going to get to hear from them after every talk. So we have 8-minute talks, a series of great imaging and physiology-focused cases. The first one is going to be given by Dr. Evan Shlofmitz, IVUS-Guided PCI, Update 2022.
Thanks so much. It's great to be here. If we could just pull up the slides for the first talk. Thanks. So what I'm going to be doing in this year in review, I'll be going over the guideline, what the latest update is, any clinical data that was published for the year, and what future trials you have to look forward to. These are my disclosures. So ACC-AHA released new coronary revascularization guidelines. They were actually published this year, even though listed as 2021. There really wasn't much about intravascular imaging in the new guidelines, despite it being a very long document, unfortunately. But there were a couple of important points that you need to keep in mind. The first was the use of IVUS for lesion assessment. As a 2A recommendation, they state that in patients with stenosis of the left main coronary artery, IVUS is reasonable to help define lesion severity. And they specify that deferral of lesions in the left main greater than 6 millimeters squared is safe for deferral. In smaller patients, sometimes, though, it's a little bit smaller number, such as in the Asian patient population. Really, the only other comment on intravascular imaging in the entire document was on the use of IVUS to guide procedures. So also as a class 2 recommendation, in patients undergoing stent implantation, IVUS can be useful for procedural guidance, particularly in cases of left main or complex coronary artery stenting to reduce ischemic events. So in the next talk, we'll talk more about procedural guidance and how to actually use that. And then at the bottom there, you see the only other comment on imaging was in patients with stent failure, IVUS or OCT is reasonable to determine the mechanism of stent failure. And I think this really is a key one, because if you don't know the mechanism, what you're treating, you have no way to figure out what the optimal treatment is. So we'll jump into the studies. Just about 2 months ago, this was published. IVUS utilization in New York State. They looked at the New York State PCI registry, a 5-year period, and looked in complex lesions, how was IVUS used? And it was pretty abysmal, unfortunately. 13% of complex lesions in New York State during this 5-year period had IVUS guidance. And there was no difference in IVUS use in complex lesions compared with non-complex lesions. The lesion subset that had the greatest use of IVUS was left main. Only a third of cases. We're competing with a lima, treating a left main, and only a third of the time was IVUS used in those cases. And in every other lesion subset, it was less than 15%. And it's actually even worse than this, because 2 of the hospitals in New York use standard intravascular imaging at more than 60% of cases. So these numbers probably are actually a lot worse if you were to remove those 2 hospitals. The good news, though, there were temporal trends that were seen in the 5-year period where there was a significant increase in utilization. But I think it's clear we have a long way to go in making intravascular imaging standard of care. The authors also reported the impact of IVUS on these procedures. And not too much of a surprise if you've been following the literature, if you use IVUS, IVUS was associated with reduction in in-hospital mortality, reduction in 30-day mortality. At 2-year follow-up, they looked at mortality and found that patients who had IVUS had favorable results. Patients who had target vessel revascularization was reduced in IVUS as well. Now, the next series of studies that were published all come from a pooled cohort of 2 randomized trials, IVUS XBL and the ultimate randomized controlled trial. So there were a series of combined analyses of these that were published over the past year. So this first one looked at patients with long lesions. So IVUS XBL was 1,400 randomized patients, all with a 28 millimeter length lesion or longer. Ultimate was an all-comer, but they excluded the 200 or so patients that had short lesions and included all those with 28 millimeters or more, and had this total cohort of patients with 28 millimeter lesions. And when they looked at 3-year follow-up from the patient level combined cohort, they found substantial reduction in cardiovascular death as well as MACE in the patients who had IVUS compared with angio-guided PCI. So you see those curves separate very early on, and it's a sustained reduction in events, whether it's cardiac mortality or MACE favoring IVUS. These, again, are randomized patients in these 2 studies, IVUS XBL and Ultimate. It gets even better, though, if you follow pre-specified IVUS optimization criteria. What the authors looked at was when that criteria was met compared with when it wasn't, what happened to outcomes. And when you have specific criteria, you get good expansion, no edge disease, no edge dissection, events almost disappear. At 3 years follow-up, it was essentially 0.5% rate in that optimal IVUS arm for both cardiac death, and it's the exact same on the composite endpoint because there was 0 MI, 0 stent thrombosis in patients who had those pre-specified criteria that were met. So I think that's pretty impactful that an IVUS-guided PCI can lead to durable outcomes. Now, the question is why? What is it that's causing this favorable outcomes? In a separate study that was published in Journal of the American Heart Association, they looked at the all-comer set from both of these 2 randomized controlled trials and looked at what procedural characteristics actually was associated with this improvement in outcomes seen in the IVUS arm. So they found 2 things: larger stent sizing in the IVUS-guided arm and more post-dilatation. So high pressure post-dilatation, larger stents lead to larger final areas. Larger final areas lead to better outcomes. And in this all-comer population, you see results significantly improved in the IVUS arm at 3-year follow-up. Of course, the naysayers may say, well, why don't you just post-dilate? Can't you get just as good of a result just from post-dilating? The authors looked at it in a separate publication. So they looked at in the angio arm when there was post-dilatation, and they saw that you did have improved outcomes with post-dilatation, if you see with the solid red line compared to the dotted. But when you compare that to the IVUS arm with post-dilatation, it's dramatic reduction in events at 3 years by using intravascular ultrasound. And finally, the last study, this was just published this week by the group at Mount Sinai, a state-of-the-art review in JACC for stent failure. Remember, the guidelines mention intravascular imaging is useful for determining the mechanism of stent failure. And if you see, the first thing on this algorithm is intravascular imaging. If you don't know what you're treating, what the root cause of that problem is, you have no way to figure out how to treat it. We have tons of tools and devices that are out, many of which you'll see in the exhibit hall later today, but you can't choose the right tool for the job if you don't know if it's underexpansion, if it's neointimal hyperplasia, neoatherosclerosis. You can't figure it out on an angiogram. You need intravascular imaging to figure it out. So whether it's IVUS or OCT, these are representative images of the different types of stent failure. You need to do a root cause analysis and figure out what's causing the problem. And finally, for the last 30 seconds, 2 upcoming IVUS trials you need to know about in the future. First, near and dear to my heart is the IMPROVE trial. It's going to be the largest randomized controlled trial of IVUS, over 3,000 patients with complex lesions. Ron Waxman's leading that. Enrollment's already begun, and it's taking place globally, but with 50% of the population in the US. And the purpose of this will hopefully be to impact guidelines and get this to class 1 indication for complex. And then similarly, IVUS CHIP is looking at the same thing in 2,000 patients in Europe, essentially IVUS randomized to angiography. So with those 2 studies, we'll have an additional 5,000 randomized patients looking at the impact of IVUS-guided PCI. So thank you so much.
Great. Thank you, Evan. That was terrific. If anyone has questions, please just stand up and we'll get you a microphone. And in the meantime, maybe we can get the panel involved a little bit. If you have questions, just let us know. But maybe I'll start with Lorenzo. I'm guessing you're an active intravascular imaging user. Maybe you can just describe when and why you use it and how you've been able to successfully incorporate it in your practice.
Absolutely. Over the past few years, I've been increasing my intravascular imaging use. I use it in every single complex lesion defined as CTOs, needing for atherectomy or lithotripsy, intravascular lithotripsy, bifurcations, particularly with two stents, left mains, in-stent restenosis. At the end of the day, ultra-low contrast PCI for advanced CKD. So at the end of the day, given the increasing complexity of the patient population we are witnessing the cath lab, really the majority of patients should get this valuable guidance. Many times, even in the past, I compare my current cases with cases maybe 5 years ago. And sometimes you see ISR, you see that the stent is smaller. You can just postulate with a balloon, but IVUS or OCT give you the peace of mind of choosing the largest possible balloon and giving really the best possible chance to your patient to enjoy improved outcomes. Particularly in case of ISR, something has gone wrong with these patients, so you need to be doing something different, and you need to be checking your intervention in the best possible way. You cannot leave the possibility that since you did not do a good job, the patient then will suffer another episode of ISR. At that point, you have 2 layers of metal, and the situation is complex, and even in the best hands, it's very hard to solve.
Great. Well, maybe, Dr. Chugh, maybe we could ask you this question. We're going to have probably 3 to 5 years minimum before we can see the results of the IMPROVE trial. And Evan, please comment as well. It's really fantastic. We need a Class 1 indication in the AHA-ACC guideline document to really have this accelerate. But we're going to have this time period of 3 to 5 years. Are there some things that we can do in this time period to try to raise awareness? What are some of the limitations to adoption that you see? What are some of the ways that we can sort of fill this gap with an understanding of imaging during this time?
No, absolutely, Dr. Jaffer. Thank you. That's a very good point. So I must say I'm probably the least gray-haired panelist here. I just finished my training, and in my eyes, when I look at an angiogram before we decide to revascularize, I'm a millennial. I honestly cannot tell you if this vessel is a 3.5, 3.75, or 4.0, and I don't know how experienced operators do that. And I think the main reason is I was trained as a default IVUS before and after. So my eyes are trained more to IVUS than they are to the angiogram. And I think that's essentially where we have to put our most efforts in, is training the sort of next generation of interventionists who will be doing this procedure. And then, I think once we do have these 2 big studies that Dr. Shlofmitz mentioned, maybe that will sort of help change perspectives of sort of more tenured operators. And I think when the financial aspects of reimbursements and how the IVUS is involved in simple and complex PCIs change, and there is financial benefit, if at all we can prove that in any way, I think that will also sort of help change this paradigm that we're trying to change right now.
Great. Well, I take offense at that comment about the gray hair, but our young buck is going to, thank you, Evan, that was terrific. Our young buck's going to give us our next talk. Dr. Chugh is going to be standing in for Dr. Kunkel and talk about his best IVUS cases of the year.
Thank you so much. Okay. So I have no disclosures, and all these cases were performed under supervision during my fellowship. So case number 1 is IVUS to penetrate the proximal cap during a STEMI. So this was a gentleman, came in, as you can see, this was an AP projection. We went right radial, and there's no sort of artery at 3 o'clock. And then take a picture of the right, you have collaterals already going up towards what looks like something that may be an LAD or a ramus or a diag. So we tried to wire this culprit. As you can see on the panel on the left, there's a large part of the myocardium that has no blood vessels. So we knew that the culprit is probably in that direction. It's probably coming off the LAD, and you can see the septal, so we thought that's probably the LAD. We just couldn't wire it, so we took an IVUS down, and I don't have a way of stopping this, but I've taken a screenshot on the right, and you can see towards the end of the IVUS run that you can actually see the proximal cap, which is marked in, and you see it right there, as marked as a red arrow. So we used IVUS to sort of find and penetrate this cap. So this was what we were dealing with before, and we were able to wire. We used a Xeon black, got in, and then the rest of the case became a lot easier. This was again going back to before, and then after, patient did very well. So again, I think lesson one for us is how CTO techniques are useful even in non-CTO PCI, and it's something that we all can use, especially for a life-saving procedure like this. Case number 2 is IVUS during antegrade dissection and re-entry. So this was a patient who was referred to us, refractory angina. A picture on the left is basically a dual angiogram showing a short RCA CTO. Distal vessel character is not the best, and there's a short bifurcation on the distal cap as well. So we did antegrade wire escalation, and as you can see, the Gaia second is subintimal. It doesn't seem like it's in the true lumen, and I don't have another picture, but we did confirm this on contralateral angiogram. Once we were subintimal, we decided to bring our Stingray down, did stick and swap, and we were able to enter true lumen, which you can see here. The wire now looks like it's intraluminal. Now our standard of care has been IVUS, again, like I said, before, after every simple or complex PCI. And you look at this IVUS run, and this is an image that you should never forget. You see a big hematoma around the vessel. And this is something that can be intentional during ADR, and this is something that you can cause an iatrogenic dissection in any normal PCI. So I think that's important to recognize this IVUS run as this being a large subintimal hematoma. And so lesson 2 from this case is recognize what is true and what is false lumen, and this will help you, get out of trouble sometimes. Number 3, IVUS to troubleshoot multi-layer ISR. As ISR is a mechanism of stent failure, 10% according to the NCDR registry. So 3 panels here. I'm sorry. So panel to the left shows it's multi-layer ISR. There were, from our understanding, at least 2 layers of stent. Severe osteal disease. We were dampened basically as soon as we engaged. So we wired with a workhorse wire, and panel number 2 is the balloon won't cross, and this is a fluoro store of us just trying to get this small 2O balloon to cross, and it just wouldn't. And then with brute force and ignorance, we somehow got the balloon in, but it was literally hanging out of the ostium. We ballooned at high pressure. And then we decided, let's just rewire. And then at this time, our balloon crossed. We took a fresh balloon, it crossed easily. We ballooned. And then in retrospect, after we did that, we went back and looked at this cine, and you can see the silhouette or the skeleton of this old crush stent at 12 o'clock. So unfortunately, and you can see on this IVUS run, but for the sake of time, we can just focus on the image on the right. We managed to go sub-stent, crush the stent. So you can see the crushed stent at 6 o'clock, and we've sort of, we've denuded intima that you can see at 12 o'clock. So again, we would not have known this if we didn't do IVUS, and I think IVUS with ChromaFlow is very useful in these scenarios as well. And then so finally, it was a little bit of a battle, went in, put in a new stent, osteal flush, and as you can see again, IVUS run shows that a new stent was pretty well optimized, and you can still see the crushed old stent on the still frame on the right, which we've sort of excluded, and this patient did well subsequently. So lesson number 3, equipment won't cross, beware, your wire can be under a stent strut. And then IVUS for non-coronary troubleshooting. This patient was referred to us for refractory angina, had a really calcified lesion at the lima Alaiti anastomosis, for which we went to intervene on. Unfortunately, this was a fluorostraw on the left. We were trying to get up this tortuous subclavian, and we injected with the pressure being damped, not realizing at that time we knew something was wrong. We then went left radial, and you'll see in a second here, if you see right there, so that's a big dissection flap. So we managed to basically dissect a large part of our left subclavian artery. We had the luxury of calling our vascular surgery colleagues to bail us out. So they went left radial and got the wire down and basically put a VBX stent to close off this dissection. And we went ahead and finished our PCI, which was also quite complex given tortuosity, issues with stent delivery, but we had a good result here. So again, I think a lesson 4 here is we all need to have some sort of peripheral bailout skills. Either if peripheral is our forte or not. And then, sorry, this is case 5. So this is a patient, Friday at 5, last case, end STEMI. He had a 10-year-old vein graft to this OM. This was going to be an easy wire balloon stent get out. So again, IVUS, we did IVUS, and we have been doing IVUS for all our vein graft cases as well. And you can see the distal vessel was around a 4O vessel. The distal graft, was a 4O graft, and the lesion was essentially a heavily fibrotic looking lesion. So we went ahead, put in a 4O DES with a filter wire, took a puff, and to our surprise, we have staining. And at this point, then had to be balloon occluded, ping-ponged, and we were able to bail ourselves out with a covered stent. So again, before on the left and after on the right, and we had good results. So I think, So I think lesson 5 is it's okay to undersize. With these old vein grafts, its perfection is going to lead to perforation, and that's pretty much it. Thank you so much.
Thank you, Yash. Very nice cases.
Thank you so much.
Again, if you have comments or questions, it looks like we might have one here. Yeah.
So what's your plan and follow up on that SVG? So SVG in the best outcome when you have excellent results, except one trial showed target vessel revascularization 6%, everybody else is 20% to 30%. Now you have a covered stent in SVG. Are you going to bring the patient back to take a look, or are you going to open the natives?
I think we have been doing it just based on symptoms. We will follow up this patient, see how he does, and if he has ISR, then probably go after the native. I don't think we'll be doing it routinely.
Well, the failure of the SVG, a lot of time catastrophic, is actually worse than native vessel failure.
Sure.
And there are trials in Europe, and actually Manos running a registry here in the US to look at the outcome of SVG versus native vessel PCI. So my advice to you is just going to take a look at him again.
Sure. Thank you.
Thanks for sharing that last case. Just on that case, and it's always really lovely when people will share not only their wins, but some of their complications. In hindsight, we were doing IVUS. This is probably the best way to size the vessel, and yet there was still a perforation. Do you remember anything about the sizing approach in that case? There's different ways to size vessels, lumen to lumen, mid-wall to mid-wall, very aggressive, EEL to EEL. And your cautionary note about downsizing a little bit, of course, makes sense. But do you remember specifically how you might have sized that vessel? And once you saw rigidity, how did you approach kind of further dilatation?
Yeah, so I think what we did was we IVUS. Distal vessel intima to intima was around 3.8, 3.9. The lesion was fibrotic. We were able to balloon it. We got good results, and just for the sake of time, I didn't show that. And we deployed our stent, our 4.0 stent nominal. So we deployed it at 12, 14 atmospheres, and unfortunately this happened. Hard to predict when these friable grafts go down.
Definitely humbling. Any other comments, Prashant? Yeah.
Yeah, fantastic cases. Congratulations. Really nice cases. And I think, again, just underlines the value of imaging. I mean, I just, looking at those cases, I just can't imagine doing them without imaging. And so I think it just speaks to, how much the field has moved. I think we're all practicing as if imaging is a class 1 indication, although the guidelines haven't quite caught up. But that's as an aside. The question I have for you is that first case that you showed with the STEMI and using the IVUS to find the cap. So typically, if you're using IVUS to find the cap and having a wire or a microcatheter in there, you need a slightly larger guide to do that. So did you preemptively go in with a larger guide, or did you then switch out when you decided that you needed to do that?
We went with the 7 French.
So you do your STEMIs typically with a 7 French?
We do it routinely with 6, but when for example, if you have a bifurcation lesion, and you want to penumbra both, a 6 French guide can only fit 1 wire with the penumbra. So we have sort of that algorithm going in, and that's basically what we did here.
Looks like we have a question.
So one of the things that I ask people that they don't do as much imaging that they bring up is the setup in the cath lab, and it takes time. So for our experience, I mean, we can talk probably a whole day about IVUS versus OCT, but whatever you pick, our experience was that the more we do, the faster it becomes. And it becomes like a routine thing to have it ready in the room. As soon as we ask for it, they just put it up. And also when you use IVUS to size the vessel correctly and just pick the right post-it balloon, you're going to decrease the time from a stepwise fashion going up to bigger balloons. So I was just wondering from the panel, what's your experience on how to make your cath lab more efficient to set up for imaging?
I can answer on that. We looked into our data in the cath lab. We're still in the low, as Dr. Shlofmitz saw in his slides. We are in the 15–16% use of IVUS. We have very big spectrum of practitioner between private and employed and university-based physician. But our protocol is to have the IVUS readily in the cath lab. It's mounted on the table, the control on the table. So it really takes 3 minutes to install. Second thing is education and awareness. We share with them the data for how the IVUS changed decision. In 33% of the time, IVUS did change position. Either you want to do atherectomy, or you thought atherectomy and you didn't need it, or maybe the sizing of the stent, you went up by 0.5 or you went down by 0.5 depending on the IVUS. So I think awareness, bring it in the faculty meeting, in your department meeting, and also sharing individual outcome with the operator and how the IVUS could have been changed the patient TVR or TLR as we discussed before.
But, we also get our cath lab team very engaged. Like when I do the sizing and try to let them know what's the lumen size and that how it changed the decision, they become actually more facile in setting up the imaging and just bring the equipment, get it going. So I think giving feedback to the team in the cath lab is also very important.
I also think a key issue is that after setting up the IVUS and running the IVUS or the OCT, what's the workflow? Who makes the measurement, does the measurements, who interprets the images? So depending on where you practice, there might be another doctor, a tech or nurse, but he or she must be specifically trained for this, because if there is no imaging champion under the technical point of view in the cath lab who performs all the measurements, you're going to be in a situation where you will end up, saying put the dot there, 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 or at the end of the day you will have to unscrub and do it yourself. So these will significantly slow down the workflow in the cath lab and will lead to frustration both on your end and in the techs and nurses end. So it's important also the logistics. I don't know if my colleagues here have, they share their experience with their recipe in the cath lab.
Well, why don't we, because we have 2 OCT talks, I think it's going to be common for both, and we can talk about that in the next panelist. So let's go on to the other half of imaging that we definitely are excited to talk about. And we're going to invite Dr. Evan Shlofmitz back up again to talk about OCT-guided PCI update for 2022.
Thanks so much. So little shift now to OCT, similar format though. So the guidelines for OCT, it actually was a big update. They recommend as a class 2A that OCT is a reasonable alternative to IVUS for PCI guidance in every single lesion subset except for ostial left main. So that was a big change. We talked about the stent failure, how it plays, and I'll take a minute to talk to you about what procedural guidance actually means. This isn't just opening up an intravascular imaging catheter, whether it's IVUS or OCT, and just passing it through a coronary and glancing at it. You don't get better outcomes from doing that. The way you get better outcomes, you need to use systematic use of imaging, and it doesn't add a lot of time. If you've never heard of MLD Max, it's an easy algorithm for how to do this procedural planning based on intravascular imaging. We came up with it for OCT, but it works just as well for IVUS. So it's two parts. You have a baseline strategized component. MLD, that's all you have to remember. M stands for morphology. What is the predominant lesion morphology? Is there severe calcification that requires atherectomy, lithotripsy, specialty balloons? That's it for M. Then you identify a distal reference. Where do you want to land your stent? You mark that. You do the same thing proximally. The distance between the two is the length, and that's the L, the length of your stent and your devices. Then you go back to the distal reference and figure out D, diameter. What that diameter is distally determines your stent diameter. That's it. It takes 90 seconds in real practice once you get experience with it. Your first time reading an EKG, it takes a long time. If you do this every case, it becomes part of your standard workflow. That's all you need to plan your procedure. Now you have the recipe for how to do an imaging-guided PCI. You then repeat the intravascular imaging at the conclusion of the procedure. You already purchased the catheter. Don't just use it at baseline. You use it at the end of the procedure too. And that tells you if there's anything to optimize the procedure further. We remember that by MAX, M-A-X. The first M is for medial dissection. If there's a medial dissection, you cover it with an additional stent. Second, A for apposition. If it's gross malapposition, you treat it with balloons at nominal pressure. That'll push the stent strut out of the way. And finally, the most important thing for long-term outcomes is X, expansion. You want to get at least 80% stent expansion, and we know that expansion is what's tied to future outcomes. So if you have inadequate expansion before the patient leaves the room, you address this to try to prevent them from coming back to the lab anytime soon. So MLD Max, that's how we incorporate our guideline-directed procedural guidance with IVUS and OCT. Now we'll shift just to some of the studies that were published in the past year for OCT. The first is called Erosion 3. It was a multi-center randomized controlled trial of patients presenting with STEMI looking at OCT guidance versus no OCT guidance. And what they found, the patients who had OCT actually had less stents that were implanted. These are STEMI patients, but if you actually figure out the root cause of the problem, what's going on, sometimes you don't need a stent. And not just were there less stents in the OCT arm, but clinical outcomes were no different, despite there being less stents that were implanted in the Erosion 3 study. So the takeaway from that really is identify the root cause before you come up with a definitive treatment. And the next study that was recently published in Your Interventions, CLIO PCI, if you haven't heard of it, it was a study that took place in Europe assessing the impact of OCT on clinical outcomes. And they specifically look at different procedural components to see what drives those outcomes. Now, they just published this 7.5-year follow-up data, so long-term outcomes with OCT-guided PCI. And the most interesting thing was when you look at an MLA cutoff of 4.5. They divided the patients, final MLA less than 4.5, greater than 4.5, easy to remember, and outcomes doubled. If you were able to get the MLA greater than 4.5, you can have the outcomes at 7-year follow-up. So they concluded that suboptimal guidance with stent implantation can be readily recognized with OCT, and these are associated with worse outcomes all the way at 7-year follow-up based on the CLIO PCI registry. Now, the next study that was recently published on OCT combined OCT FFR. So the overall cohort was published last year in the European Heart Journal, but this year they published the diabetic subanalysis. So this was a prospective, double-blind natural history study looking at OCT in the sub-study in diabetic patients. And what they found, lipid-rich plaque was associated with worse outcomes at 18-month follow-up. So they looked, you see lipid-rich plaque, that's the vulnerable plaque. These are the non-obstructive lesions that cause future MI. So lipid-rich plaque, patients who had that identified in OCT had a 7% event rate at 18-month follow-up, and that's compared to less than 2% in those without lipid-rich plaque. But it gets more interesting when you dive into the lipid-rich lesions and really look at what the composition is. Because of the high resolution of OCT, you can actually detect the cap thickness and measure the cap to see if it's thin. And when you look at patients who have thin cap, there was a 13% event rate, compared with less than 3% event rate when it was a thick cap. So significantly fourfold higher event rate when it's TICFA. And that makes sense. Those are the plaques that are prone to rupturing. And I think this is really interesting because there was a separate randomized trial that was just published in JAMA called Pacman AMI. And what they did, they took patients presenting with acute MI, they did baseline imaging on the non-culprit vessel and found patients who have lipid-rich plaque and have TICFA. And these patients with TICFA were randomized to one of two arms, high-intensity statin or high-intensity statin plus a PCSK9 inhibitor. They all came back a year later and repeated that imaging. And what the investigators just reported was there was actually plaque regression in the patients with PCSK9. So there was plaque regression, but beyond just plaque regression, when they looked at that OCT cap thickness, the cap, which was the same in both arms at baseline, 1 year later, the patients on PCSK9 inhibitors, it went from an average of 33 microns to 62 microns. You can thicken that cap, and we know if you thicken that cap, it's less likely to rupture. So you have plaque regression and stabilization of the plaque with high-intensity statins and PCSK9 inhibitors. The exact same findings were seen in a separate study called Huygens as well, so I think really novel for future pharmacotherapy as well. Lastly, there's a new OCT software that's out that everyone should be aware of. So Abbott makes software. They just released something called Ultron, and it incorporates artificial intelligence to basically automate that entire MLD Max workflow that we just talked about. So when there's calcified lesions, you don't have to be able to recognize this. This is automated with the Ultron software. Anywhere calcium is, it shows as orange here on the baseline OCT. It tells you the angle of calcium and the maximal thickness. You also get precise measurements. It identifies the EEL, the vessel size, with that dashed white line, and tells you precisely the diameter and the length. So you have the whole procedural planning that's automated. And finally, stent apposition under expansion is also automated with Ultron as well. All these numbers are automated, so this is something that you can do in under a minute. You can do a procedural guidance with intravascular imaging when you're using the latest software. Now, finally, with future studies, there's a lot more studies with OCT. The biggest landmark one that has completed enrollment called the Lumion 4. Results will be out sometime in the next year, but over 3,600 patients were randomized to OCT versus no OCT, complex lesions, complex patients, and we're looking forward to those results. There's also a number of other studies here that will all be looking at the role of OCT in both complex lesions, calcified lesions, and an all-comer subset. So we'll have several thousand more randomized patient data over the next couple of years. So thank you very much, and happy to take any questions.
Great. Thanks again. A terrific talk, Evan, and nice summary of the data. Maybe I'll get Robert's opinion. Evan was talking about stent malapposition and edge dissection. How do you decide how far to chase this and which malapposition you can leave or edge dissections you can leave, and what do you use with intravascular imaging to help you guide that decision?
Sure. I mean, I think just from a 10,000-foot perspective, I think OCT is the sort of really nice illustration of why we still have poor intravascular imaging permeation in the U.S. Our two big issues, as have been mentioned, is really reimbursement and education. People simply don't know what they're looking at, and people are always hesitant to do something they're not paid for, regardless of whether that's right or wrong. It just is. And so I think OCT really illustrates that well. We're often left with a significant amount of information, and the question still is, which are significant predictors on what's actually going to affect my patient's long-term outcomes? There's a significant amount of data that's come out from both St. Francis, friends at Columbia, really helping us to understand what are these criteria. And Evan's already mentioned Lumion 4 coming out. We're going to see some great criteria. They're going to have a large patient set to really help us with that, expand further on the MLD max. Obviously, there's a lot of IVUS data out there as well, whether you want to look at IVUS XPL, you want to look at how they did that sizing, various ways, whether it be 80 to 90% expansion compared to the distal vessel, whether it's looking just straight at an MSA, and then looking at the extent of the section into the media and how far it goes in terms of arc and length. Those are the big things really when, for our majority of IVUS users, it's going to be looking at that dissection at the edge, right? How far it extends, length, help you determine whether you have to take care of it. I think MSA is a little bit easier for those of us doing complex lesions because honestly finding a healthy segment, trying to figure out the 80 to 90% can be challenging. So just looking at that cutoff of 5.5 millimeters squared I think is helpful often at times. And then ensuring that you don't have big plaque burdens at either edge. We typically kind of use that 50% cutoff. Again, hedging a little bit around these numbers because these numbers aren't perfect, but they are good guides.
Yeah, I wonder in the studies that have shown suboptimal IVUS or OCT results lead to suboptimal outcomes. Are those because the operator, just ignored it, or are they just cases where you can't optimize it and, because of, whatever issues with the coronaries? And how do we change that? Are they modifiable, I guess, is what I'm getting at.
And I think Ultron is potentially great, depending on the ability to get market permeation, but the Ultron can never, ever sort of be in place of physician education, right? And so what we have to do is get physicians understanding what they're seeing and then have an AI sort of automation that really helps us, right? But it cannot replace our understanding what's going on.
Evan, a question for, thanks Rob. Evan, a question for you. So you've spoken on both. Should we do IVUS? Should we do OCT? Either or maybe both? Because we now have systems that are combined. We have one commercial system already available in the United States that is a combined IVUS OCT system, so you get both best worlds. What do you think?
So you need to use one of them. As long as you use intravascular imaging, that's going to be what allows you to improve your outcomes. I think in about 80% of lesion subsets, you can use either one. It comes down to operator preference in the lab that you're in. There are distinct advantages of OCT versus IVUS for specific lesion subsets. If it's an osteal left main, I'm using IVUS. If it's calcified lesions or ISR, I'm using OCT. The majority of cases, I tend to use OCT. That's my favorite device, but I still use about 25% IVUS, and the remainder is OCT. So I think it comes down to patient preference, operator preference. As long as you know how to use one really well, that will account for, that can be your workhorse, just like you have a workhorse wire, and sometimes you need a specialty one. You should be familiar with both, but as long as you're using imaging, you could get that improved outcome.
Just a question here. So, the recent guidelines make a distinction between IVUS and OCT in the setting of left main imaging. So what do you think about that? Do you think there is a role for OCT in left main imaging? There are some that do use it. What are your thoughts on that?
Yep. So what the guidelines specify for using for deferral, IVUS is the only thing that was validated, and that, of course, is just because of the data. I think they're interchangeable devices, personally. The issue with OCT in a left main is clearance of blood. You need to clear the blood, and it's a lot harder in a larger vessel. So if it's a distal left main, we get great images with OCT. Osteal, it becomes a little more difficult. I still, for most left main, I'm using IVUS as the predominant modality. But for procedural guidance, you can use either or. So again, for assessing severity and for deferring, that's where IVUS is per guidance, per the guidelines. But for stent expansion, you can use either one to determine what that final stent is. And that's really going to be the #1 predictor is the final stent area. A larger stent, it's going to take longer time for that patient to restenose.
If you ever want to counter to the argument that imaging adds time to your procedure, go watch some PCI at St. Francis, and that will change your mind. I mean, it's crazy. It's amazing.
And because it's standard of care. If an indiflator is opened, they open an imaging device. Your only choice is which device. We have over 90% intravascular imaging. And then this was systematically assessed in Disrupt CAD3, the shockwave study. They had an OCT subarm and a non-OCT arm. OCT had a minimum of 3 OCT runs in every single case, and it actually was 2 minutes quicker, those cases, versus the cases that had no imaging, because you know what you're dealing with up front. You have your procedural planning, and we're doing this anyway when they're going to get the equipment. I'm analyzing the imaging when someone's running to get the equipment anyway, so it really doesn't add much time to the procedure, and it impacts your patient's outcomes. Thanks so much.
Great, terrific. Thank you, Evan. So we'll move on. Dr. Amer Alaiti will show us his best OCT cases of the year.
Thank you. The answer to actually the last question about IVUS versus OCT is absolutely OCT. And for left main PCI, you absolutely can use OCT except for osteo left main. So my name is Amer Alaiti. I'm going to talk to you today about my best OCT cases of the year. And just, how do I advance this? Okay, this is my disclosure. So when I asked myself what would be my best OCT cases of the year, the answer came very loud and clear, the cases of ISR after the previous IVUS guided PCI. So the first case, we're going to actually talk about 2 cases, both left main. You can see the image on the left, pre-PCI, distal left main diseased, post-PCI in the middle, and then now severe ISR of distal left main. The second case, also severe distal left main in the past, pre-PCI, post-IVUS guided BCI, good results, great results, now severe ISR. So the first case is 69-year-old male with end-stage renal disease on hemodialysis, prior left main LAD PCI with hemodynamic support, non-surgical candidate, presented with unstable angina. Again, the previous PCI was done. You can see the caudal images on in the upper panels and the cranial images on the lower panels. It was done 9 months ago, IVUS guided, orbital atherectomy, provisional left main to LAD stenting. Now you can see there is now complex distal left main, ISR involving distal left main, ostial circ, and OCLAD, as well as actually ostial high diag that you can see on the lower panel on the right. So the approach was that obviously we elected for hemodynamic support with Impella CP, 8-French femoral access, and EBU guide. PCI approach, we decided to go with DK crush for the left main, and for the high diag, giving it so close to actually ostial LAD, we decided just like simplify the strategy with provisional stenting and just keep it open and pre-dilate. So wiring all 3 branches, serial balloon dilatation, followed by double and triple kissing balloon inflation, and then OCT, guided PCI, DK crush. On the left is the OCT into the circ, on the right OCT into the LAD. We already, by looking on you can see the co-registration angio, by just seeing these markers, you already decide where you're going to land your stent. We already decided about the stent size and length, and we already decided about the balloon for post-dilatation. Similarly, on the right panel for the LAD. So all of this equipment, after these 2 runs of OCT, were asked for and they were ready. So that saves a lot of time, no guessing. Interestingly, we felt that the most likely explanation for this ISR is stent fracture. As you can see, actually, on the lower part of this image, there is gap in the box, in the lower box. There's about 2 to 3 millimeter gap actually in the stent, corresponding to that area on the distal left main. And you can see actually on the cross-sectional OCT, the absence of stent struts. You can only see the wire actually shadow, but you can see the stent. So again, proceeded with the OCT-guided PCI, DK crush sequence. You can see the landing of the CIRC stent on the right upper panel, corresponding what OCT guidance telling us where to place it, similarly to the LAD on the lower panel, corresponding to the coregistration image. Followed by final balloon inflation, 4.5 millimeter balloons in both branches. And of course, you image pre and you image post to make sure that you did the best you can to avoid future ISR, especially that you are dealing with an ISR already. So you can see the OCT into the CIRC on the left, OCT to the LAD on the right. Excellent expansion, no edge dissection. You can, if you look just more carefully, you can see on the left panel at the very ostem of the very beginning of the left main, not the ostem because you cannot really see it very well, but you can see there is a little bit of malapposition with the arrow, red arrow. And that just become, to be honest, clinically is not that significant. It just because it's all still left main, we decided to tackle it for possible future interventions so you don't damage the stent. So basically, post-dilated that again with 5O balloon. And this is the final results. And the diag stayed open according to the plan with very good results. Obviously, I look at the angio, but I decide about the results based on OCT first because there's stuff you cannot see on angio only. So that's the first case. The second case is a 68-year-old male with a prior complex PCI to left main LAD and CIRC with hemodynamic support, also non-surgical candidate, presented with NSTEMI. You can see again the pre-image, pre-distal left main disease, and the pre-PCI, post-PCI. This was 5 years ago, IVUS, orbital atherectomy as well, mini crush technique, but because of whatever reason, looks like the ostium of the CIRC was missed, so it needed another stent actually to cover that ostium that was crushed also. So you have probably multiple layers of metal in that distal left main on one side. No post-PCI imaging. Now again, presenting with this severe complex distal left main. So the approach also hemodynamic support. For this case, I elected radial access 7th French. And the approach also DK crush for this distal left main, PCI of the OM ISR, and I decided to debulk the left main into the LAD with rotational atherectomy, given the fact that there was actually severe calcification, severe tissue proliferation, as well as multiple layers of stents in that distal left main. And that was achieved by rotational atherectomy 2O burr, left main into the LAD. As you can see, multiple runs to make sure that appropriate debulking was achieved. And followed by OCT into the CIRC and OCT in the LAD. You can see that the planning of each stent is very clear based on the coregistration. You can decide again about the location of the stent, the diameter and the length, and the post-dil balloon. Similarly for ostial CIRC and left main LAD DK crush, all the stent sizes and length and position perfectly matching what the OCT telling us. And this is the final results after following all the DK crush algorithm or sequence. Oops. Okay, so just conclusion, obviously it's highly recommended, and I believe that it should actually be mandatory to use routine imaging pre and post PCI procedure for planning and optimization. And of course, for ISR, it's absolutely a must because you want actually to avoid it in the first place. But once you have it, you really want to make sure that you're giving this patient the best second chance, because after that, things are going to be way more complicated. Thank you very much.
Great, thank you. Beautiful cases. Evan was quite diplomatic when asked about OCT versus IVUS, and the gloves came off right away in your talk. Were you implying that the IVUS-guided cases, if they had been OCT-guided, they wouldn't have reached stenosis, or?
Honestly, when I made this slide, I did not know that most of the panel will be IVUS, but, but actually, I think, again, it backs to whatever you you comfortable with. I think honestly, and I'm biased because I'm like more OCT, I do think that OCT give you way more data, and which can be overwhelming for new users, but I think with IVUS, you still got to have some faith in what you're seeing. I think a lot of stuff you're seeing, and people can argue, are we seeing this, are we seeing that? OCT, you will see it for sure. You can see the dissection, edge dissection, and you can see it, there's no question about it. Then you can decide if you need to tackle it, if it meets the criteria or not. I think with IVUS, still there's some guessing. I honestly believe so.
Can this come on? Thank you. So those are great points. Great cases, really complex cases, really wonderful job technically on both of them. A couple thoughts. I think, just to kind of frame where OCT really has an advantage is when you're looking at the surface, right? 10 micron resolution versus 100 micron resolution. So mechanisms of ACS, mechanisms of stent failure, and then maybe one other added advantage is calcium thickness. So in your case here, you actually used a 2.0 burr, which actually I didn't realize you could get through a 7 French very routinely. So that was great. But did you use imaging at any point to decide your calcium modification strategy, and how did you kind of pick your burr size? Why did you go from 1.5 all the way up to 2.0, and did you do that sequentially? Did imaging help guide that decision?
So yeah, I mean, this is a great question. Honestly, I usually obviously start with the imaging to kind of decide vessel size and match as much as possible, like safely, the maximum that I can do, like burr size, okay? But for this case, I actually went ahead with the atherectomy before because I did not want to start dilating and causing some dissections and things like that. I wanted really to debulk. And the size of that is basically by looking at the previous cath, that they really got excellent results expanding. So all the metal is probably out of my way, and the stent, like they use 4.0, 4.5, balloons. So I know 2.0 still, although it looks like big, but still for that left main into the LAD will still be actually maybe 50%, size. So that's how I chose that. But for most of the time, 90% of the time, 95%, if you can get the OCT catheter through the lesion and still image it, that's what I do to decide on the size.
Another specific question on that case. I think some people worry, you had a basically subtotally occluded circ ostium as well, and they worry about, doing atherectomy down the LAD and somehow further compromising. What's your experience and how do you, approach that concern?
So I obviously actually thought a lot about this possibility before I did what I did. But the decision was this is actually clearly, even if I get flow from the left main to the LAD and even lose the circ, the patient still do better. But my concern was actually losing the flow, LAD and circ, and that was my attention paid to that all the time. And that's why you needed Impella, and he did become very hypotensive during these zones, as you can imagine, because it's obstructive. Now what happened actually, yes, we did lose the flow to the circ. And that's something I did not totally not expect, but we were able to actually get it by workhorse wire, because after that atherectomy, not much dissection, like all debulking, right? Would actually, you can imagine, would actually be easier to get to the circ at that point. So that's what happened.
Did you have access to the index procedure IVUS imaging to elucidate what went wrong? As we know, IVUS does not work by intention to treat. As Rob pointed out, there must be significant education. So it's not just that you throw an IVUS in and expect that the result is going to be good just for the sake of it. So did you have access to the IVUS imaging?
Not to the IVUS images, but to the angio. And from what I could tell on the angio, that there was no post-PCI IVUS. It was done in the middle to decide about something, atherectomy or something, but...
Which again goes
of course.
Along with what Rob said about the education. So it could have been also easily vice versa. They did OCT in the first case, and then you did IVUS on the second one.
It was just meant to be provocative, for IVUS versus OCT.
And any info on the follow-up of the patient, because they had ISR, so maybe these are the rare cases that you might be willing to bring back to the lab for angiographic follow-up.
That's absolutely valid. Just to be honest, I depended on the clinical, how they're doing clinically, and up until actually, 2 days ago, they were alive and actually had outpatient visit, and they were actually asymptomatic. I think you can, but basically, for sure, like bring them back and take a look. But we decided that would be more clinically driven.
Now, one quick question. So excellent cases, again, congratulations. One question is about contrast use and whether you use saline sometimes. So for example, if you do this decay crash and you're going to image 5 times, you have, maybe in the patients with CKD might be an issue with contrast. So do you ever use saline, especially on the right coronary artery? And how do you minimize the contrast when you use OCT?
Right, so great question. I think obviously they don't recommend you use it. You can use it. I have not used it yet. The way I do save contrast with these cases is basically no angio done without imaging, if possible. So if I'm doing angio, it's with imaging. So, and that's the best way to save contrast, because most of the time for people who don't use imaging, use it as bailout, they've done already 3-4 angiograms trying to answer the question, and then they still cannot tell, and then they use the OCT, or imaging, and then that add more contrast. But all the angios are as much as possible done with contrast. But yes, you can do saline. It's not recommended, for multiple reasons, but you can.
Great.
Saline in my IVUS. So you can use saline when you IVUS.
And what?
Thanks, Rob. Thanks.
I think we better move on. Great, thank you for that talk. I know everyone's very interested in intravascular imaging, but the real reason you're here is for the coronary physiology section. So we're going to move on to that one. And none better than Arnold Seto to kick that off, talking about coronary physiology update 2022.
Well, I can think of one person who's better at this than I would be, and that's Bill, of course, who's taking a leadership position in all of these areas. So it's my pleasure to give this update in 2022 on coronary physiology. I'm going to do something a little different, where I'm going to talk about angiographic FFR, coming of age, coronary flow measurements as a new or old frontier, and then FFR versus imaging guidance. I'm not going to talk about FAME3 or Flower AMI. I'm going to let Bill talk about that during the discussion. As we may know, there's now 3 FDA-approved angiographic FFR systems, QFR, FFR Angio, and VFFR, that are available to take your cath lab images that are optimally taken and convert that into an angiographic estimate of FFR. This is, of course, separate from the heart flow FFR, which is a non-invasive CT, which in MedAxiom's estimation will reduce your number of diagnostic casts even as it increases your interventions. And the structure of it is that angiographically derived FFR is obtained from using optimal 2D angiography with 10-inch without panning, 3D model reconstruction, stenosis reassessment, and hemodynamic evaluation, either with computational flow dynamics or, in the case of CathWorks, a non-CFD estimate. All these forms of angiographic-derived FFR have a pretty good correlation with FFR, with an R value of 0.81 and a reasonable spread and without bias compared with FFR. So this is an update on where we are in the market right now. QFR is associated with ASSIST and has had some recent studies, which I'll go over, but all 3 of the angiographic FFRs have validation against FFR. CathWorks was recently had a purchase option just last week from Medtronic for $585 million, demonstrating that there's big money and big commitment from industry, showing that this will be clinically relevant. CAS VFFR is active in Europe, but probably has the least market penetration so far in the US. And that too has a validation study, but has a non-inferiority study in progress. So I just want to go over the most recent study for QFR. And QFR really has taken a leadership role here, I think, because they've really partnered with the high volume centers in Asia, especially China and Korea, to get these really awesome clinical outcome studies. And this is effectively the FAVOR 3 China study, is a high volume 3,800 patient study that compared a QFR guided strategy versus an angiographically guided strategy, similar to FAME. And basically, QFR was performed if the QFR was less than 0.80, and angiographically it was performed if, based on the local practice. And what they found was that you actually had fewer stents placed if you used QFR, and had a lower and an improved outcome. So here's the I apologize. This slide set was changed without my knowledge, but you actually changed your revascularization strategy 24% of the time with QFR compared with angiographic guidance, and the primary endpoint was actually reduced with QFR to 5.8% versus 8.8% with angiographic guidance. So to summarize that study, in 3,800 patients, you actually were able to analyze QFR in 97% of cases that changed the revascularization strategy in 24% of patients. It led to fewer vessels being treated, less stenting and less contrast use, and reduced one-year MACE. So the strengths of this study was that it was very large and it had blinding of patients and the evaluators. The limitations was that it was open label to the operators and not a comparison with FFR directly. And so those two non-inferiority studies, similar to Define Flare and Sweetheart, those are ongoing with QFR and with VFFR. So to summarize angiographic FFR, this is really going to change your practice. It's going to be faster, simpler, more comprehensive with a 3-vessel analysis. You won't have to necessarily do pullbacks because that will be incorporated within the analysis. QFR has now achieved outcomes data equivalent to FAME, but had a 3 times larger patient volume. And QFR and FFR VFFR have non-inferiority studies planned. And I think this leads to an interesting question. Will we as operators consider all these angiographic FFRs the same as a class because they correlate the same with FFR, or will there be one winner? And I would submit that it's probably going to be a class effect, and that anybody who can come up with a reasonable correlation with FFR will probably show a benefit. And that leads to the question, well, which industry partner will win? And I think that potentially the image companies like Philips and Siemens may have the advantage in that regard. What are the barriers to use of angiographic FFR? Right now, all the companies are trying to make back their money with a per-use sales model of $500 per use, just basically for software analysis. And I would use angiographic FFR for every one of my cases if I could just purchase it outright and just push a button. And I think this model may be a challenge for uptake in the US. In addition, there's no current reimbursement in the US. And this slide will show you that. It's currently under a T code of 0523 T code, which is not approved for payment in most of Medicare. And this is going to be renewed in possibly 2023. So all the angiographic FRs are potentially usable with this T code, 0523. That doesn't prevent you from charging, of course. If you're Cedars-Sinai, you could try to charge $20,000 for this angiographic FFR, along with charging $200,000 for that defibrillator gen change that costs you really only $35,000 or $40,000. Interestingly, missing on from this slide was a physician reimbursement. There's actually some Medicare companies that actually will pay the physician anywhere from $33 to $130 for angiographic FFR. And interestingly, this is actually more than the $77 they'll pay you for a wire-based FFR. So for the physician, not the institution, you actually might be doing better with angiographic FFR one day. All right, I'm going to shift gears, and then, so for angiographic FFR, that's the future. I think that's going to be replacing wire-based FFR in the near future for all of our practices. We're going to talk about coronary flow in the next talk as well, but I just want to highlight a couple of things in the market. Corventis has become widely available with Abbott distribution. FDA was approving it in 2020. In contrast, the Doppler wire has been discontinued by Philips, and those of us who still have a few combo wires and combo maps in our labs are seeing them wither away quickly. The barriers include requirement for IV adenosine, the lack of additional reimbursement compared with FFR. It's sometimes technically challenging to master, and unclear treatment regimens are still an issue for coronary flow. One thing that's interesting to remark on is that there's the correlation between Doppler flow and thermodilution coronary flow is somewhat weak at somewhere about 55 to 80%. And then the correlation with the gold standard of non-invasive nuclear O2 PET is also somewhat weak. It's a little better for Doppler, a little weaker for thermo, but at this point in the market, you only have thermo available. So that's what you got. So with thermodilution CFR, you can take with the CoraFlow software, you can measure IMR, FFR, and CFR all at once. So you can take a vessel like this, which has a diffusely diseased RCA, and convert that to an angiogram. So from that angiogram, you can get the CFR, and you can tell that this diffusely diseased lesion, which we were prepared to shockwave and stent the entire vessel, actually has a negative FFR, and more reassuringly, a negative CFR and IMR, indicating that this doesn't need to be fixed at all. So that's very exciting. And then I'll let Olga talk about the Cormica trial, where you can actually tailor your treatments according to what you find in the CFRs and the IMRs, and actually improve your outcome, because your Seattle Angina questionnaire will actually improve with appropriate treatment for microvascular or spasm dysfunction. I want to finish up by saying that there's a recent trial from OCT guidance versus FFR guidance. So there's FFR. We traditionally say that FFR is good to determine whether the lesion is something that you should treat, and then you use IVUS or OCT to determine whether you should treat it afterwards. But of course, you can use post-PCI FFR or IFR to determine whether you've done well enough. So this is a trial from 2019 demonstrating that OCT guidance versus FFR guidance, both pre and post-PCI, might actually have different outcomes. And at least this trial suggested that OCT might actually be better than FFR. But it was a small trial of 350 patients, and so that kind of led to the Flavor trial, which was just presented at ACC, which indicated in 1,700 patients that you could actually, with pre and post FFR versus pre and post IVUS, you could actually show that you could reduce the number of stents placed with FFR guidance and yet still have similar outcomes. So the post-PCI MSA for IVUS was pretty high at 7.0. The post-PCI FFR was pretty good at 0.88, and the outcome was no different. So what does this tell us? Well, it tells us that you have to do something pre and you have to do something post. But maybe, at least in this study, that FFR was non-inferior to IVUS in terms of reduction, with a reduction in stenting compared with the outcomes. So this is kind of intriguing, although our paradigm should still be to potentially use FFR pre and IVUS or OCT post. We've already heard from Evan and others that you could use OCT or IVUS before and OCT and IVUS afterwards. So this debate about whether you should use imaging first or physiology first is kind of put into question. You should do something at first before PCI. You should do something afterwards, but it's not clear whether you need to do both. So this complex algorithm here by Colette may not need to be done in all cases. I think all of us could then debate as to whether it should be done in selected cases. So thank you very much.
Great talk, Arnold. Thank you. I think that probably the key question here, and Bill won't like this comment, that you might have to choose. You have a certain amount of resources and time in the lab. You know this question that's coming. How do you choose between, is it imaging or is it physiology? And because if you default both, you're obviously going to increase time and cost. So how have you been thinking about that most recently?
Well, we're a physiology-first lab, of course, at Long Beach VA. So we do physiology on every patient, pre and post, and both IFR, FFR, and then we'll do IVUS in about 25% of cases. So that's at least our practice, but I know everyone will differ.
And I think the good news is that there are a number of groups working on imaging-derived, intravascular imaging-derived physiology assessments as well, so that you could get both information with one device, and that could be quite useful. And also your comment about the angiography-derived physiology, if that is routinely available on every angiogram at a little extra cost, that could also make it easier. You can use still your intravascular imaging, but get your non-invasive or non-wire-based physiology.
I would like to make a comment about angiography-derived physiology. So I don't think this field, under the practical usage standpoint, will gain much adoption unless we change this system. You explained that the cost is $500 per case, or anyway, on a case-based fee. So I think in Europe, the way the QFR works, for example, is like a gym membership. So you pay a fixed monthly fee, and you do as many cases as you want. So in that way, you will really do physiology on every single case. So I think that unless the system changes in that direction, this field is not going to expand much. What do you think?
Yeah, I think that's a great point, Lorenzo. I've approached every company and said, hey, the VA won't let me do a per-use charge, these little vouchers that they want to sell us. I need to buy it. I'll pay you $500,000 even. I just need to buy it outright. And no one would let me do that. And so they need to consider other models because, like you say, I think that I would use it in every case if it was just by push a button, and that's really all it could be. It could be we just do it by push of a button, and we just need to purchase it as hardware, I think.
Question?
Thank you for your presentation. I want to ask you, what is the role of physiology in the assessment of significance of left main physiology? Do you prefer to go with IVUS or OCT, or you will go with physiology for the left main
Great question. So the question was whether we need to use left main physiology versus IVUS. I think this is an open question in many ways. If you have unopposed, isolated left main, everyone would agree that that FFR is valid, widely valid. And of course, Bill has done research in animals and sheep and simulated in humans that your lesion has to be very proximal and very severe to impact on the FFR of the left main to make it inaccurate. So FFR is still valid in the left main. There's new data about IFR in the left main. And of course, the IVUS is still valid with the MLA greater than 6. So the answer is you still have a choice, and I'm sure there's a lot of opinions on this panel.
Yeah, I'll give my opinion. I think this is the case where you open up both. If you have any question, if one isn't giving you a clear answer, you bring in the other to make sure you get it right.
I think that's fair. I think in cases where it's clearly severe by imaging, which does have a larger evidence base based on the Litro study and other IVUS trials, there's probably a larger evidence base for guidance of left main PCI with IVUS. But in those gray zones, it's absolutely super helpful to have physiology to substantiate a major decision for the patient.
Yeah, I think the left main is a great use for physiology in those cases where you have just funny, like maybe osteal tapering that in some views looks bad and other views looks totally normal because you get a lot of mock effect. And I think you often will get a normal FFR or IFR in those settings, and it can be more reassuring and save the patient from an unnecessary procedure.
To the first question, whether use IFR for physiology versus imaging. Again, if the lesion is intermediate, and we know from the physiology trials, you differ more by doing physiology. So if I am not convinced this is a critical lesion or this is not what brought the patient to the cath lab, definitely I will start with FFR or physiology. If this is something significant and I have an evidence from non-invasive testing before putting the patient on the table, I just want to evaluate the morphology of the lesion, then it will be the IVUS. If for after results, and I agree with Dr. Seto about the comment, it's becoming routine for us to do post-PCI FFR because you have it there, it's connected. Hopefully the wire didn't dislodge or not damaged by or being reconnected. But if all of this are rolled out, I think post-PCI FFR is really helpful data for you.
All right, great. Thank you, Will. Really good discussion. And we're going to finish this very exciting session with a super important topic that is really emerging and helping us understand a substantial group of people with post-PCI angina. Dr. Toleva is invited to speak about spasm and microvascular dysfunction, how to assess in the lab.
Good morning, everyone. First of all, I'd like to thank for the invitation to present here at this meeting. It's been really great learning for me. And also, the talk before me was a great segue to the topic I'm going to discuss today. I have no disclosures. So assessing spasm and microvascular dysfunction in the cath lab could be challenging. I'll try to make it simple and discuss the ways we do it and the role of functional coronary angiogram, the different medication we use to provoke the different pathways. First of all, ischemia with open coronaries have become something that is on the rise, and a lot of people are trying to deal with it in their clinical practice. INOCA is something that has been investigated for more than a decade. And again, we still have questions about INOCA, what is slow flow, what is myocardial bridge. So I'll try to make things simple and see if you could come out of here with an algorithm that will help you make the diagnosis. Also, epicardial vasospasm is something that I encourage most of the practitioners to start testing. In this COVADIS group, which is basically the base of the Cormica trial, you could see that only 11% of the patients who had chest pain actually had non-cardiac cause. And the vast majority had an explanation. About 50% had microvascular dysfunction, 17% had vasospasm, and there were about 20% combination of both. So this just leads to tell that it is very important to do a comprehensive testing. A lot of us rely on a normal angiogram, and then patients could be just reassured there's nothing wrong with you and discharged home. But the reality is that we have an armamentarium by which we could make a diagnosis. In some centers, we would use a PET CFR or sometimes MRI, but this only gives us an idea about the microvasculature based on flow. It is more important to know that invasive measures remains to be the gold standard. And we have the tools to do that in the cath lab with either thermodilution or Doppler studies. We also could utilize different substances to test both the endothelial-dependent and independent pathways. Here's an example of how we can approach the circulation of the heart. Of course, we're all familiar with the epicardial arteries and the FFR and baseline indices like IFR, RFR, etc. So we all have become very comfortable that if we see an epicardial stenosis, we can make an assessment for it. But what is challenging is that the microcirculation is actually invisible. So how do we assess that and how we make a diagnosis when we identify that the FFR is normal? Well, we have the option of CFR, and CFR is coronary flow reserve, which is a summation of the perfusion through the epicardial and microcirculation. So if we give adenosine and dilate the microcirculation, it gives us an idea of the ability for the microcirculation to allow blood supply to the myocardium. More recently, as you heard, the Doppler wire has been discontinued, so CFR and IMR are now measured through thermodilution, and IMR is a more specific measure, which is the index of microvascular resistance. So it gives us a true idea of how the microcirculation is acting on stress. And on the other hand, provoking spasm with acetylcholine has become more popular, and more practitioners are comfortable using it in the cath lab. This gives us direct idea of how the vessels contract if there is evidence of visible spasm, but we also talk about endothelial dysfunction or microvascular spasm. As Ziad likes to call this the alphabet soup of microvascular dysfunction, I would just want to point out two important indices that you have to be comfortable and familiar with measuring. One is the coronary flow reserve, and the other one is IMR. There is emergent continuous thermodilution index called the microvascular resistance reserve that has not been validated yet, but may be something that you may be curious and interested about. Here are the components of a functional coronary angiogram. The most important thing is that the patients have to be off vasoactive drugs for at least 24 to 48 hours. This allows you to really provoke all the pathways. You could test the endothelial independent pathway with adenosine, where you directly measure CFR and IMR through the wire components, and this could be done through IC or IV adenosine. The endothelial dependent pathway is being tested with acetylcholine, and if you visualize spasm, you make a diagnosis of Prinzmetal's angina. If you don't see severe spasm, then you're left with a diagnosis of either microvascular spasm or endothelial dysfunction. Here is just an example of how we measure with the Doppler wire, where you do a baseline flow measurements, and then it's basically a ratio between your hyperemic flow and your baseline flow. So this is the pitfall of CFR. If you have a high baseline flow, you could measure low CFR, but does that mean that the flow actually is low? And also, this CFR Doppler measurements have been validated in multiple studies in the WISE cohort through Noel Berry-Mertz group. And you could see here that patients who had open coronary arteries and reduced CFR had poorer outcomes than the ones that had normal CFRs. So that's why it is important to know who are the patients with low CFR. More importantly, nowadays, we use the CoroFlow system, which is easy to utilize, it's faster, and it's very user-friendly. And some of you are probably familiar with the thermodilutional methods. What we do is we measure transit times. So it's an injection of saline, which is vigorous, it's 3 cc, and we measure baseline transit time, which is in blue, and then we give adenosine, which is a hyperemic agent, and then we measure transit time during hyperemia. Again, CFR is just the ratio between the two transit times. So, and also is affected by the epicardial circulation. But when it comes to IMR, we could specifically interrogate the microcirculation and discover if there are any specific abnormalities related to microvascular dysfunction. Here's an example of a workflow of a patient who as you could see here, had normal appearing coronaries at baseline, and in blue are the baseline transit times with saline injections, and then after giving IV adenosine, we had measured the transit times during hyperemia. So in this case, we made a diagnosis of microvascular dysfunction both by IMR and CFR. So this is the easy case. It makes sense. Then on top of it, this is the combined endotype where by giving acetylcholine, we identified that there is also epicardial spasm, which reversed with nitroglycerin. What is important to know about this particular method is that there could be huge variability between the boluses, so the technique has to be mastered, and also you have to pay close attention to the position of the wire, because if it changes, it may change the distance, and then the transit time could change and may give you variation in the measurements. As you can see here in this example, there are huge variability in the measurements during hyperemia, and sometimes after the hyperemic stimulus wears off, you could end up with all kinds of numbers, and you could pick and choose and build frustration. However, if you master it and you're comfortable with it, it's a very good and fast method. I could do a case for about 45 minutes in the lab. Now there is this emerging new technology where you don't have to use a hyperemic agent. You basically infuse through this microcatheter a continuous infusion of saline into the coronary, and at 10 cc per minute, it gives you baseline absolute flow, and it's called continuous thermodilution. And then after 2 minutes, we increase to 20 cc per minute, and then it breaks down the red blood cells, releases adenosine, and gives you a hyperemic measure. So there's something that maybe in the future may be interesting, but it still had not been validated. The catheter is supposed to be available by the end of this year. So what do we do with discordant measurements? How do we interpret these? So these are some of the questions that we ask ourselves. For example, in this paper that we published, patients who had low CFR but normal IMRs basically had just very high baseline flows, and that's why their CFR was low. So it is important to measure both CFR and IMR to make the proper diagnosis. So this is the algorithm that I use in the lab and how I make the diagnosis based on invasive measurements. With adenosine, I make a diagnosis of microvascular dysfunction, non-endothelial pathway based on IMR or CFR. With acetylcholine, if I see spasm, I'm pretty certain to make the diagnosis of Prince metals. And those in between are still probably something that we need to do more research to be sure of how we identify microvascular spasm. Is it a true diagnosis? Is there any other endotypes hiding behind this? So in conclusion, INOCA endotypes are various and distinct, but often overlapping, as I could show you in this case. It is important to measure both CFR and IMR to make the proper diagnosis and to test both endothelial and non-endothelial pathways. So it is imperative that we not only use adenosine, but we also use acetylcholine in our testing to make a comprehensive diagnosis. And we still work on consensus on protocols and how we actually do these measurements in the cath lab. Thanks for your attention.
Thanks, Olga. That was great. Question.
Dr. Toleva, great presentation. And the actual question was the same for Arnold as well. So very interesting, the data on the continuous thermodilution. You know, many of us in our practices have been primarily using Doppler. And with, I think Arnold alluded to this, that will be discontinued or not available for some time. And a phenotype that we've been concerned that we may not identify, and I'll be interested in your opinion, is that of the endothelium-dependent phenotype of microvascular dysfunction that we assess with continuous velocity with the acetylcholine infusion. And how is that an important phenotype that we miss if we only have thermodilution?
Yeah, I absolutely agree with you on this. So I actually made a trip to Aalst to see how they do it in the lab just before, about 3 weeks ago. And so we had a discussion with Dr. De Bruyn about actually doing continuous infusion through a microcatheter of acetylcholine while you're running the saline infusion. And he kind of encouraged me to see if this is something that we could do in the lab. Again, the microcatheter is not available until the end of the year, but some of the core flow systems, like including the one I have in my lab, has the option to do continuous thermodilution. So it's a very simple protocol. It doesn't take much longer, and of course it's not operator dependent. It basically is something that is very easy to perform. They use the big injector, the old MedRad injector, to infuse the saline through. Again, it's very new and has not been validated, and we still have to make sense of those numbers. But it would be something that, again, is very interesting.
Catheter is the Rayflow, right?
It's the Rayflow catheter, yeah.
Yeah, so you cannot use a regular microcatheter because the jet of the saline will just be directed in one direction, and a regular microcatheter would not allow mixing of blood with the saline, whereas the Rayflow is like a multi-hole catheter, like the pigtail, so it allows a proper mixing of blood and saline.
It has 4 holes that are at 90 degrees angle from each other. So he had done some bench models where he did like dual lumen catheter, and it was not reproducible. So it has to allow proper mixing and a circular motion in order to do the proper measurement.
Hi, I'm Timir Paul, working at St. Thomas Hospital in Nashville. So I have a couple of questions, most related to protocol. First, can you do radial all these cases, or by default yours is femoral? We're doing all femoral because of not using, I don't have to use the verapamil or nicardipine for that.
This question comes up all the time. There's a lot of operators that do radial, and it's perfectly fine because you need a 6 French. The only caveat is, if it's a small, tiny woman and you don't use anything in your cocktail, you just go without. Sometimes after you induce the spasm with the acetylcholine, you may induce radial spasm as well, and may be difficult to remove. So these are kind of considerations, but a lot of people do radial. I personally still default by femoral because most of my patients are young women, and even just the pain from going through the radial sometimes without the cocktail could trigger spasm in the ones that have true Prince metals.
Next question is, if you have CFR, what is your, we traditionally see the less than 2 or less than 2.5. I did a case last week, CFR came like 2.2, and Amer came exactly 26. It's kind of borderline. Yeah. And how is it? Are you dead set in 2.5 or 2?
There's a recent paper that actually came out, a correlation between Doppler CFR and thermodilution CFR. And in this paper, when they did the simultaneous measurements, they actually recommended that the cutoff for thermodilution goes to less than 2.5, but the accepted limit in the core flow right now is 2.0. So it's just a matter of validation. In general, with thermodilution, I really rely more on the IMR measure than the CFR, and I don't know what you think, Bill, about it, but...
Yeah, I mean, I think you alluded to the issues that we see sometimes with CFR where it can be low because of fast resting flow, and whether that is another endotype of microvascular dysfunction or not, I think is still open to question. I mean, clearly, CFR has been correlated with adverse long-term outcomes, but again, is it just picking up, older people with more, diastolic dysfunction and LVH and hypertension, or is it actually, due to microvascular dysfunction? I think we still need to figure that out. So you have to kind of incorporate both pieces of data. I think what we could say is IMR is more specific for the microvasculature than CFR.
And my next question is, we're trying to write a consistent protocol, but do you do acetylcholine challenge test first and do the other microvascular next, or you do the microvascular first and acetylcholine next? Because if you do the microvascular first, you do adenosine, wait for another 5 minutes and do the acetylcholine.
I think that the camps divide into 50-50 on this. I personally do the adenosine first and then the acetylcholine, but a lot of people do the acetylcholine first, so that way there's no interaction with any other medications, and once they finish that, then they give the nitroglycerin and continue with adenosine.
It may matter if there's moderate coronary disease, because if you do adenosine first, in that case it's significant, you will go on to PCI. Some people will also do, I think, adenosine, acetylcholine, and then adenosine one more time. But anyways, we probably are a little bit past the hour. Thank you so much for attending. This was a really exciting session. My thanks to all the speakers, our panelists, my co-moderator. Enjoy the rest of the morning. Thank you.